Good afternoon, and we're ready to start our series of webinars with Brenda Edwards. Just a little bit about Brenda. One thing before we get started, if you're on by phone, make sure that you put in your full name, not just your last name. We need full name so we can track this for MGMA Kansas purposes. So thank everyone. Thank you all for joining us. Just a little bit about Brenda. I think most people know Brenda. She is the Director of Auditing right now at Crossroads Health Resources. She has been involved in healthcare arena for over 30 years with experience in chart auditing, coding and billing, education, consulting, practice management, and compliance. She's worked closely with practices, providers, and residency programs to ensure documentation is compliant and accurate. Brenda has written many articles for national publications, including Healthcare Business Monthly, American Academy of Family Physicians, and BC Advantage. Her humorous and engaging presentation style has made her a conference favorite at national and regional conferences for AAPC, AMBA, and Decision Health, as well as local chapter meetings across the country. She's been a National Advisory Board member for AMBA since 2018. She served on the AAPC Chapter Association Board of Directors from 2010 to 2014, and she held office as chair. Mentoring fellow members of AAPC and AMBA is a passion for her. She is co-founder and of the Northeast Kansas AAPC chapter and has served many offices. So Brenda, we thank you for doing this for us. And I'm just going to let you go ahead and take over. Thank you.
All right. I told Denise not to read that whole crazy thing, but we see she didn't listen, but that's okay. Good afternoon, everybody. I see lots of familiar names in the attendees. I'm excited we're all here. John, there was one question, where do we put our full name in the chat box? So you want to answer that one and I'll get going?
It should be in the upper right-hand corner of your own video box. There should be a rename on there. I'll check that out just to make sure.
Okay, and can you verify, John, you're seeing my full-size screen right now?
Yes, I am.
Okay, then let's get rolling. Denise mentioned I am Director of Auditing at Crossroads Health Resources. I'm sure a lot of you are saying, what's that? Real quickly, if you weren't aware, the company I worked with, SCBI, closed September 24th, and Crossroads Health Resources is the new company that I am working with. If you would like more information, my email is on here. Please reach out and I would be happy to talk to you about it. Pretty much I'm doing the same thing I've always done, just with a different company name. So enough of that, right? Let's get to ICD-10 updates. Not like we don't have enough to worry about with COVID and now flu season and E&M changes, ICD-10 changes. I'm going to start by showing you, where do you find this information? I know there's a few weirdos like me, like Stacy Barrett and Tracy Bird, that we watch closely for any new information as it comes out for coding updates. And the two resources that are the best place to look is either CMS and CDC. And I've got links at the bottom of this slide that shows you how to get to each one. Each one is going to have a breakout of different content that you can download. The one, if you do not have new coding books right now, the most important one I would pull down is the coding guidelines for this for 2021. There are some significant changes in COVID-19 that your staff needs to be aware of. I did some work with some coders recently that didn't have their new code books and were running into problems with codes getting denied, and it was for that very reason. There's a lot of narrative changes. Some changes are going to be so minor, it might be a period in place in a code. It could be a bracket instead of a parenthetical. I've tried to include most of those here. There's a total of 490 new codes, 47 revised and 58 deleted. Now, the thing to know with the 58 deleted, most of them have been made into a subcategory. So now they're going to have at least 2 or maybe even up to 5 or 6 subcodes. And that's where that 490 number comes in. It's expansion of codes that we've already had. We're up to 72,616 codes for this year. Effective date was October 1st. And if you are making sure that your software is up to date, your EHR is pulling correct codes, and that your staff is aware of that. So we're going to start with some general coding guidelines. If you have any difficulty in locating in the guidelines, this 1B14, keep in mind that the guidelines have the general guidelines, and that's 1, and then the second section 2 is the chapter specific guidelines. So this is a broad guideline for social determinants of health. This has been added. Patient self-reported documentation may also be used to assign codes for social determinants of health, as long as the patient self-reported information is signed off and incorporated into the health record by either a clinician or provider. We're going to start seeing more and more about social determinants. That's going to be part of what decision-making will take into consideration next year. We've seen an increase in those diagnosis codes a few years back when we switched to ICD-10. These slides are available on the MGMA website if you go out there and check for them. Okay, in the general guidelines, a lot of revision changes, spelling and minor revisions. Some of it's in the word order or removing repetitive words. Laterality, 7th character, affects the total number of codes. And so that's what I mentioned earlier. If we had a code, for example, headache has broken out into 2 codes this year. And if there are codes for eyes or musculoskeletal, anytime there's a laterality, that's going to increase the number of our codes. Chapters 2, 8, 9, and 12 have no changes. And I do have a slide up for them just as a reminder which chapters that applies to. So we're going to jump into infectious parasitic diseases. There's 7 new codes, and these are around the encephalitis, tick-borne encephalitis codes. There's some tabular changes, and there are going to be changes that excludes 1 because of our new COVID-19 code that actually we've been using almost all year. So let's get started. The coronavirus guidelines have had extensive changes. And this affects dates of service 10/1 of this year forward. So the guidance that we were given back in April during the pandemic at the height of this is that we could code presumptive positives. And that guideline has changed now. We only code confirmed cases of the 2019 novel coronavirus as documented by the provider or documentation of a positive COVID-19 test. So that presumptive positive has been pulled out. The remainder of this guideline stays the same. Then going on, all of that presumptive positive language has been deleted. And now we have instead code signs and symptoms reported. So anytime there's a suspected, possible, probable, inconclusive, or even presumptive, now we're going to go to signs and symptoms instead of the previous guidance that we had. Continuing on, this is COVID-19 meets the principal diagnosis. We use U07.1 sequenced first. And the part of this that was deleted is only pertain to pregnancy being the only exception when there are more cases than just that. So that was removed. And the new language is to use U07.1 sequenced first, except when another guideline requires certain codes be sequenced first, such as obstetric sepsis, or transplant complications. There's also a reference for COVID infection in newborn, and then the infection in a lung transplant patient, and a reference to take you to the transplant complications. The acute respiratory illness due to has been changed to manifestation, and then the language below that. And this follows what we've been doing already, and that's when the reason for the encounter or admission is a respiratory manifestation of COVID-19. The U07.1 is sequenced first, and then the respiratory manifestations are sequenced after that as additional diagnoses. So that doesn't change sequencing order that we already had in place. And then you can see some minor changes for a patient with pneumonia confirmed as due to COVID-19, assign U07.1 and then your pneumonia code. That same language change will take place for the respiratory failure and any other respiratory conditions. There's a new guideline for non-respiratory manifestations, and that is when the reason for the encounter admission is a non-respiratory manifestation, and the example is viral enteritis of COVID-19, assign U07.1 as the principal first listed, and then assign manifestations as additional diagnoses. This exposure to COVID-19, this was the rule that we had been following to use Z11.59, I believe. Patients are in the exposure to, look at the bold, for asymptomatic individuals with actual or suspected exposure to COVID-19, assign Z20.828. And then for symptomatic individuals with actual or suspected exposure to COVID-19, and the infection has been ruled out or test results are inconclusive or unknown, assign Z20.828. So a lot of this language has changed. When we get to this next one, the screening for, and I apologize, this is the one that's the Z11.59. This language has been removed. During COVID-19 pandemic, a screening code is generally not appropriate for encounters for COVID-19 testing, including pre-op code as exposure to COVID-19. Coding guidance will be updated as new information concerning any changes in the pandemic status becomes available. Maybe I'm presenting, I'm on a webinar. Sorry, guys. So this language is very different than what we were using previously. Excuse me. Get out of here, leave. Okay, sorry, guys. So the Z11.59 is removed. Instead, and this guideline is kind of iffy to me, the exposure, when we're testing for preoperative, code is exposure to. So whether or not the patient has known exposure, we're going to code it this way. And I do believe we will see changes on some of this guidance as the pandemic ramps back up. Going on, the signs and symptoms without definitive diagnosis. The big change here is under the asymptomatic individuals who test positive. See guidelines 1C, 1G, 1A. Instead of assigning the U0.1. Although the individual is asymptomatic, they have tested positive, is considered to have COVID-19 infection. Moving on, we have finally clarification on personal history of COVID-19, and that is to assign Z86.19. Follow-up after COVID-19 infection has resolved. You're going to use Z09 when a patient is seen for follow-up evaluation and COVID-19 test results are negative. Then we're going to follow that with Z86.19, the personal history of other infectious and parasitic diseases. So these are some guidelines that we had kind of questioned in the past. What would we do? And we've gotten our clarification now. And encounter for antibody testing, we are going to use Z01.84. Encounter for antibody response examination, and then follow the guidelines if the individual is being tested to confirm a current COVID-19 infection. Okay, that's all of the COVID rules. Now let's get to tick-borne viral encephalitis. This A84.8 was the previous code that we had available. And now it has been expanded to include Powassan virus disease and then other tick-borne viral encephalitis. The incubation period is a week to a month. The Powassan is a serious disease, usually resulting in encephalitis and sometimes can lead to death. A lot of these infectious disease conditions have very similar symptoms, which are pretty vague: fever, headache, vomiting, weakness, confusion, loss of coordination, speech difficulty, seizures. This had been a disease that was occurring in the Northeast and Great Lake regions of the US. Patients may be asymptomatic initially, but the cases have increased over the past few years. One reason that the code has been introduced is to monitor the spread of the disease, but also to make sure that the blood supply is safe. Now we have bubiosis, and this is a previous code that has been expanded out, and it is a tick-borne infection infecting red blood cells. It's a week to 4 week incubation. And then there are the different types due to, so you can see the microtie, Duncani, divergens. It's one that started on the West Coast, but now is progressing into Canada. Again, it's another one that they can track. There is a higher percent of elderly or immunosuppressed patients that may have more severe illness. Okay, moving on to neoplasms. We don't have any guideline changes, no code changes. There's just some minor revisions that I've got listed here. And the main one is the eosinophilia, because we've got some new codes for that section. In Chapter 3, blood-forming organs, 43 new codes, 3 deleted. Those 3 that were deleted have become a subcategory, and that's where this increase of codes comes in. It's all sickle cell. Well, most of it's sickle cell. There are some codes that have been revised, and you can see those here: D57, 411, 12, and 19. The unspecified has been added into the first 2 codes, and then the unspecified has been moved to be in sequence with the other 2 codes on D57419. So we are going to look at a lot of new codes. 21 new codes expanded in the sickle cell category. D57.0 was in existence. It has had D5703 and 09 added. And what you'll see all throughout the sickle cell code range is that they're going to have different complications with them. So, for example, here with cerebral vascular involvement or with crisis, you do need to make sure you're watching for the code alsos and the use additionals to tell the full story of the condition. The hemoglobin sickle cell is the most common and most severe form. We have sickle cell HBC. This code has been expanded out again to show that with cerebral vascular involvement, with crisis, and then with crisis unspecified. Here's some more. These are sickle cell thalassemia with cerebral vascular involvement with crisis. So we're going to see this same pattern throughout. Here's the sickle cell thalassemia beta 0 without crisis. This one produces no hemoglobin. Excuse me. And then continuing on in this same category, the with crisis with acute chest syndrome with splenic sequestration. And then on to the vascular involvement with crisis with other specified complication or unspecified. Finishing out this group, the without crisis or with crisis. This is thalassemia beta plus. This there is some normal hemoglobin, but in reduced amounts, and the symptoms are less severe than other sickle cell. Continuing on with the beta plus, the acute chest syndrome, splenic sequestration, and cerebral vascular involvement. And finishing out that group, the with crisis, other specified complication or unspecified. The hemoglobin S beta causes symptoms similar to sickle cell disease, but it is less severe. Okay, now we are in sickle cell disorders other. So when we don't have any of those that we've already gone through that fully describes the situation, then we want our providers to report other, and that it has the involvement along with it. Okay, now we are at anemia. These are the autoimmune anemias. If malfunction of the immune system produces autoantibodies that attack red blood cells as if they're foreign bodies. There's a couple of different types here. We have warm autoimmune hemolytic anemia and cold. The warm means that the autoantibodies attach to and destroy the red blood cells at normal temps. The cold is when the body temp is well below normal. Okay, eosinophilia, I mentioned this a little bit earlier. This is eosinophilia is a higher than normal level of eosinophils. This is a type of disease-fighting white blood cell. Usually indicates parasitic infection, allergic reaction, or cancer. And you can see we have the different syndromes, the hyper eosinophilic, idiopathic, lymphocytic, and then other or unspecified. Okay. Drug rash with eosinophilia and systemic symptom syndrome, that is DRESS syndrome, and watch for your use additional and code first notations as well. Immunodeficiency due to conditions elsewhere classified. This is 4 new codes that have been expanded out of the D8 4.81. The code first and excludes applies to all of these codes. So we have the immunodeficiency due to drugs, due to external causes, and then the other immunodeficiencies. And then we have cytokine. Cytokine release syndrome. Cytokines are small proteins. They act as chemical messengers for communication between cells. The condition can occur after treatment with some types of immunotherapy. The thing to notice on here, there's a grade 1 through 5, and I am not clinical, as many of you know, but this came from one of my friends who is an RN, and it's the Penn table that relates to the grades of cytokine release syndrome. There's 3 different grading scales, but none of them show grade 5. So something to keep in mind. Excuse me. Moving on to endocrine, we have 6 new codes. And we have some guideline changes. In diabetes, and the use of insulin, oral hypoglycemics, and injectable non-insulin drugs. The addition is if the patient is treated with both insulin and an injectable non-insulin anti-diabetic drug, assigns Z79.4 for the long-term current use of insulin, and then Z79.899 for the other long-term drug therapy. If the patient is treated with both oral hypoglycemic drugs and the injectable non-insulin anti-diabetic drug, assign Z79.84 and the Z79.899 for the other long-term drug therapy. And that same rule applies in secondary diabetes. Quickly, John, I don't need to worry about these people that need let in from the waiting room, do I?
Oh, I'm sorry. I'm taking care of those.
Okay, I just see them popping up and I keep thinking, I hope I'm not ignoring people.
Nope, I'm doing it.
Thank you. Okay, we are at aromatic L-amino acid decarboxylase deficiency, AADC. This is a rare disease. It needs early detection. Average onset of symptoms is 3 months of age, but it can be up to toddler age. It affects a lot of systems. Most cases, they are going to present in the first few months of life, and most of the patients do not make it beyond the first decade of their life. We also have new codes. This is another rare genetic disorder, and it is glucose transport. And there are type 1, and you can see within there, there's syndrome 1 and syndrome 2, depending on the onset time frame. This has a broad range of symptoms: abnormal eye, head movement, body movement disorders, developmental delays, cognitive impairment, slurred speech, language abnormalities. Other changes, one pattern that I've noticed this year is a number of excludes 1, which means you can never code the codes listed there in addition to the code you're looking at. A lot of those have changed over to excludes 2. So now you can code more of those conditions together. So make sure you're checking the book or watching your software if you're using that version instead. Okay, moving on, mental, behavioral, and neurodevelopmental. There's 21 new codes, and they're all related to substance abuse use with withdrawal. So we're going to start with some guidelines. Psychoactive substance use unspecified. The addition to this is codes are to be used only when the psychoactive substance use is associated with a physical disorder included in Chapter 5, such as sexual dysfunction and sleep disorder, or a mental or behavioral disorder such as, such a relationship is documented by the provider. This is the category of all of the new with withdrawals. You can see the category down the first column and then going across the different levels: uncomplicated, delirium, perceptual disturbance, or unspecified. Nervous system, no guideline changes. There are 24 new codes and 5 deleted. And this again is an expansion of existing codes. The early onset cerebellar ataxia has been made into a subcategory, which includes the 3 codes here on the slide. The Friedreich ataxia is a multi-system neurological disorder, has symptoms for gait, balance instability, coordination, loss of sensation in arms and legs. It's estimated that there are thousands of people in the US that present with this between ages of 10 to 16. Some of it can start as early as age 5 and even up to the age of 25. These codes had specific codes assigned to them in ICD-9, but when we moved to ICD-10, we lost that specificity. So now we're just bringing it back up to what we had previously. This first one, G40.42, cyclin-dependent kinase-like 5 deficiency disorder. When you look at that first acronym, CDKL5, I've been cautioning coders, be careful, because if you look at that quickly, you're going to think it's CKD5, which is chronic kidney disease, and we want to make sure we're not transposing anything. Dravet syndrome, you can see these are in infancy. These are developmental encephalopathies. These have a lot of different complications as well. Some of these have seizures related to them. The Dravet's is a severe type of epilepsy characterized by prolonged seizures beginning in the first year of life, and it is another rare condition only affecting 20 to 40,000 people worldwide. Notice that the last 2 codes, the G40833 and 34, are with or without status epilepticus. Myopathy codes, the G71.2 has been expanded. These are, of these, the core myopathy and multi-mini core myopathy are the most common. Some of these show up also in neonates, but some of the conditions may not even show up until adulthood, and facial weakness, and then non-progressive weakness is a symptom. Life expectancy is normal, but most patients may end up in a wheelchair. Okay, cerebral spinal fluid leaks. We have a number of fluid leaks here. Again, another category that has been expanded. We have the cranial and then cerebral spinal fluid leaks that are spontaneous, other cranial, and other spinal. So watch to make sure you're choosing the right cerebral spinal fluid leak category, spine or cranial. Perineural cyst has been increased and includes cervical nerve root, lumbar nerve root, sacral nerve root, Tarlov, and thoracic nerve root cysts. Hypotension, we've got intracranial hypotension new codes. Notice that there's code also, a large section that applies to all of the intracranial hypotension codes below, and that includes the unspecified, spontaneous, other, or unspecified categories. Continuing on, this is intracranial hypertension following lumbar cerebral spinal fluid shunting, and then following other procedure. Both of those have a code also for what it was related to. Other changes you can see on this slide, we have excludes 2 added for headache with orthostatic positional component, and excludes 1 to 2 change, and then spelling, spacing, minor changes. I and adnexa, 29 new codes, 7 deleted. And you got it. Those 7 deleted have become new codes that have right, left, bilateral, and unspecified. And these are hereditary corneal dystrophies. So you can see each of these are going to multiply out. Typically, the 6th character of 1 identifies the right side, 2 identifies left side, 3 is bilateral, and 9 is unspecified. So all of the different types of corneal dystrophies, and it continues on the second slide here. Any of these little grids or cheat sheets or any of the presentation that's helpful to your providers or your coders, please share it. It's public information. It's not like I have anything secret in here. The other code in the I section is H5581, had a revision from saccadic eye movements to deficient saccadic eye movements. And there's a new code H55.82 for deficient smooth pursuit eye movements. All right, ears and mastoid process. We don't have any changes, deletions, revisions this year. Circulatory, there are no new, deleted, or revised. We do have some notations that have changed. The exclude 1 changes to an excludes 2 in cardiac arrest. The cerebral infarction adds and excludes 1 for neonatal cerebral infarction. And then the atherosclerosis, which is a pretty large section, has inclusion terms for all of the codes for chronic limb threatening ischemia and critical limb ischemia. It's kind of rare that we don't have much going on in the circulatory. We do have a guideline change, and this is a good one to have clarification. Hypertensive CKD and acute renal failure for patients with both acute renal failure and chronic kidney disease. The acute renal failure should also be coded, sequence according to the circumstances of the admission encounter. That's one that's been around for a long time. Do we code both or do we not? Respiratory, we have 6 new codes, and we have guidelines, of course. The vaping-related disorders, now this may not seem new because we started using this back at the beginning of the year. Patients presenting with conditions related to vaping, assign code U07.0. Keep in mind that the U category of ICD-10 codes are emergency use codes. So our first one is the vaping related. Our second code is COVID-19. So they're not going to fall necessarily within the same category, but they are there because we needed codes added quickly. So the vaping related, for lung injury due to vaping, we only assign U07.0, assign additional codes for other manifestations such as acute respiratory failure or pneumonitis. Associated respiratory signs and symptoms due to vaping are not coded separately when a definitive diagnosis has been established, but you would want to list other symptoms such as gastrointestinal symptoms in addition to the vaping code. We have some eosinophilic pneumonia codes and asthma codes that have been added. Notice the JA2.83 has code first, type of asthma, mild, moderate, severe. We don't have unspecified asthma here, so we really want to encourage our providers to be specific on the type of asthma our patients have. Interstitial lung disease with progressive fibrotic phenotype. This code was created, actually these two subcodes were created to differentiate the conditions. We do have code first notes for both of these that you need to keep an eye on. Other changes, there's some excludes 1, 2 changes as well as instructional notes. And further on, we've got some influenza and asthma additions due to that eosinophilic code that was added. In the digestive codes, we have 11 new and 5 deleted. The deleted codes, again, created a new subcategory, and these are combination codes for bleeding. K2080 is the other esophagitis without bleeding, and that includes abscess. The K2081, other esophagitis with bleeding, and then the K209091, esophagitis unspecified with or without bleeding, and K210001 are the GERD with esophagitis without or with bleeding. Have a few more digestive code additions, the Ogilvie syndrome and the other specified functional intestinal disorders have been created. And then we have the hepatic fibrosis codes that have been broken out. And so we can now have a code for stage F1 or F2, as well as a stage F3. Other changes, there are some language changes throughout the excludes ones, changing to excludes 2, as well as some additional notes, code alsos. The skin and subcutaneous, no additions or deletions. There have been some minor revisions in a couple of codes. The L57, there is a revision to include other non-ionizing radiation, W90. And then the other change is in L98.4, the varicose vein code has expanded and now goes up to I83.93. Musculoskeletal, we have 57 new codes, 3 deleted. The majority of these are other specified joint, other site. I'm just going to give my 2 cents on this. These are very non-specific codes. We want to really encourage our providers to code as specific as possible. Other specified means there's not a code that describes the joint that is being addressed. It does not mean it's an unspecified and you can just use that as a quicker reference. So we have multiple categories that are going to be in this other specified site, and it starts out with rheumatoid arthritis. These are with rheumatoid factors, and again, they're all of other specified sites. And then the second code is, or I'm sorry, the third code is the rheumatoid arthritis without rheumatoid factor, other specified site. This group applies to the juvenile rheumatoid arthritis with systemic onset, and then the periarticular and the unspecified. So remember, these are, again, vague codes. Primary osteoarthritis, other specified site, as well as post-traumatic, and secondary osteoarthritis. Rounding it out here, we've got the other cartilage disorder, disorder of ligament, pathological dislocation, recurrent contracture, ankylosis, and then other specified joint derangement. So every category that was already out there in musculoskeletal has had this other added to its specificity or lack thereof. Other instability, other joint, pain and other specified joint, and stiffness, other specified joint. So again, if you look at pain in joint and there is not a joint that is represented specifically, then you want to use the other specified, not unspecified. Transmandibular joint disorders expanded to indicate arthritis and arthropathy, and again, laterality. So we're going to have one for right, left, bilateral, and then the unspecified. And encourage your providers to please not use unspecified. We know payers, and our local Blue Cross is one of them, that if you submit an unspecified code, it will deny. And when we have the specificity in the code, there shouldn't be a need for that unspecified code use. The osteoporosis categories have expanded out. Age-related osteoporosis with current pathological fracture, other site, and then the other osteoporosis with current pathological fracture, other site. The other osteoporosis may be due to drugs or other factors, not necessarily the wear and tear older population osteoporosis. Also, these codes are going to require 7th character that's going to talk about the healing status. These codes are 5 characters long. So the M80.0A will need an X for that 6th character, and then your 7th character. Same thing applies to the M80.8A. It'll need an X, and then the state of the healing is, or the healing is listed in the 7th character. Okay, juvenile osteochondrosis. We have referred to these as Blount's disease and Osgood-Schlatter disease. The AAOS has requested modifications to distinguish the difference between the two conditions better. The Blount's disease is a growth disorder of the tibia that makes the leg angle inward, so it looks bow leg. Osgood-Schlatter is a disease of soreness and swelling at the tibial tuberosity. They both occur in adolescence. And as I said, the AAOS wants these better clarified. And of course, there's going to be a code for right, left, bilateral, or unspecified leg. Other changes are listed here. There are excludes 2 changes, as well as some excludes 1 that changed to excludes 2. Genitourinary, we have an excludes 1 and inclusion terms that apply to multiple codes that are listed, and it's all related to the C3 glomerular nephritis. Sorry, can't say that one very well. And then N20.1, the calculus of ureter, has an inclusion term to include ureteropelvic junction. So our stricture codes that have increased, the N35.814 actually had a change in language, and it just takes out a redundant anterior 2. The N39.0 adds and excludes 1 for pyuria. Then the breast lumps, unspecified lump for right and left breast, now has an overlapping quadrants. So if the 1 o'clock and 3 o'clock quadrants both have lumps, you would code this as the overlapping instead of the 2 separate. N92.4 had additions for perimenopausal bleeding and perimenopausal menorrhagia or metorrhagia. And then N99.85 is a new code, and that is for post endometrial ablation syndrome. These are all of the new codes related to G3. Glomerulonephritis, that's a hard word. It is a rare renal disease. It's been distinguished as a disease for about 10 years. Renal failure typically develops in half of the patients within 10 years of presentation. A curative treatment is not available yet. So all of those, remember, have an excludes one note that you need to watch for. Another change we have, N18.3, the CKD stage 3. We now have CKD stage 3 unspecified, 3A and 3B. So what's the difference? The 3A is the GFR of 45 to 59, and the 3B is GFR of 30 to 44. So the question has come up at almost every presentation, and that is, can a coder code based off of a GFR? And the answer is no. The provider needs to document the stage of CKD. We can't use that GFR solely to determine that. And that comes from coding clinic guidance. Other code, the granulomatous mastitis has increased for specificity, right, left, and bilateral. This one is a little different. The unspecified is the first listed, and then the 1 is right, 2 is left, 3 is bilateral. We have 5 new codes in the pregnancy, childbirth, puerperium. The puerperal sepsis 085 should not be assigned for sepsis following an obstetrical procedure, and it has a reference to this sepsis due to a post-procedural infection instead. The other guideline changes are related to COVID-19, and that is during pregnancy, childbirth, puerperium, when COVID-19 is the reason for admission encounter. You're going to use 098.5 sequenced first, followed by U07.1, and then any manifestations go after that as additional diagnosis. The O category always takes sequencing priority. If the reason is unrelated to COVID-19, but the patient tests positive during the admission or encounter, the appropriate reason for the code for the reason of the admission encounter is sequenced as the principal, then the 098.5, and then the U07.1, as well as any COVID manifestations. So that is one of the few exceptions in that Chapter 15 sequencing rule. 036.83 has added a number of maternal fetal heart conditions to that category that was already in existence. We have new codes for maternal care for other type of scar from either previous cesarean or a cesarean scar defect. And then other specified diseases complicating pregnancy in either pregnancy, childbirth, or the puerperium. Our perinatal codes, we have 4 new and some new COVID guidelines for infection in newborn. Guideline here again, if a newborn tests positive, assign U07.1 and the appropriate associated manifestations. For a newborn that tests positive for COVID-19 and the provider documents the condition was contracted in utero or during the birth process, assign P35.8 and U07.1. And then when coding the live birth episode, you have to use the appropriate code from the Z38 for the place of birth and the type of delivery as the principal diagnosis. There's some new language for the newborn affected by other maternal conditions. And then the neonatal cerebral ischemia has a new excludes 1. Neonatal cerebral infarctions, we have new codes for the laterality. So the P91821 through 829, again, right side, left side, bilateral, or unspecified. Congenital malformations, we have one deleted code, that's Q51.20. And the other three codes, Q5121, 22, and 28, have been revised. The first code is complete doubling of uterus. The second one is partial doubling. And then other and unspecified doubling of uterus now becomes Q51.28. Signs and symptoms, not a lot happened in here this year. We do have the two new headache codes. R51 was expanded. R51.0, headache with orthostatic component, and that includes positional, headache with positional component, and then headache unspecified, which includes facial pain. Some abnormal findings, R74.01, elevation of levels of ALT, AST, and then the R74.02 is for the LDH. The S&T codes, no surprise, has the most number of code changes, 23 deleted. Those 128 new are because of that, and it is laterality, as well as the 7th character, which could be multiple 7th character codes depending on the healing status. These are superficial injuries to the thorax, and it includes bilateral and middle, plus the 7th character. So it's not as bad as it sounds. Some of the revision notes, we've got some excludes 1 that changed to excludes 2. And here is a couple of graphs of the thorax codes. It's going to be laid out like the other injury codes, and that is contusions, abrasion, blister, external constriction, superficial foreign body, insect, and other superficial bite. And those all are going to have a bilateral and a middle choice, as well as each of those codes will have an A, D, or S for initial encounter, subsequent encounter, with routine healing, or a late effect. Poisoning, adverse effects, underdosing of fentanyl, fentanyl analogs, tramadol. These all now expand out into the accidental intentional assault, undetermined adverse effect and underdosing, as well as other synthetic narcotics. And those all need the appropriate 7th character. These are 6 characters long, so you don't have to worry about that X placeholder. Corneal transplants, these codes have been expanded. So now we have laterality for each of the complications. So rejection, failure, infection, other or unspecified complications. Okay, this is the VWXY category. These are the external causes of morbidity that some payers require, some do not. I hear more and more offices use them. I think they're a good additional code to use. Remember, they can never be a primary diagnosis. Think back a couple of years ago, Christmas presents were hoverboards and Segways. So guess what? We have codes now for people that got injured on them. Most of these codes are hoverboard or Segways, and they are pedestrian or whatever that person is on that micromobility device running into somebody or something. So we'll kind of go through these categories. The V0003, this is for a code added for a rider of a standing electric scooter or a rider of another micromobility pedestrian conveyance. The V0084 is accident with the hoverboard or Segway and include codes for fall from, colliding with, stationary object, other. Again, remember, these are add-on codes to help tell the story. It will be used in addition to what the injury actually is. So is it a broken ankle, sprained foot, sprained wrist? This goes after that. So this group of codes, we've got pedestrian on standing micromobility pedestrian conveyance. injured either in a non-traffic, a traffic, or an unspecified traffic or non-traffic accident. This group of codes is that pedestrian on that micromobility device colliding with the 2 or 3 wheeled motor vehicle in a non-traffic, traffic, or unspecified accident. Then we have that same pedestrian colliding with a car, pickup, or a van in a non-traffic, traffic, or unspecified. Seeing the pattern here? This group is the pedestrian injured in a collision with a non-motor vehicle in a non-traffic accident, traffic accident, or unspecified. Whew, that's a whole lot of codes. Y77.1, this is a therapeutic, non-surgical, and rehabilitative ophthalmic devices associated with new adverse incidents. It has been expanded out to have an entry for contact lens associated with adverse incidents or other therapeutic, non-surgical, rehabilitative ophthalmic devices with adverse incidents. Again, these are secondary codes. You'll use these after whatever the injury is for the eye or adverse incident. Okay, this group of codes had some revision in language. The dirt bikes, apparently not enough drivers, passengers, and persons on the outside of the dirt bike were being injured because we're deleting those 3. Again, secondary codes. Our influencing factors influencing health status, the Z category. We have guideline changes. Observation codes are primarily to be used as a principal first listed diagnosis only. An observation code may be assigned as a secondary diagnosis when the patient is being observed for a condition that is ruled out and is unrelated to the principal first listed diagnosis. The example here, patient presents for treatment following injuries sustained in a motor vehicle accident, also observed for suspected COVID that is subsequently ruled out. Also, when the principal diagnosis is required to be a code from Z38, you're going to report that for the birth and delivery, and then a code for Z05 for the observation, the Z3 after the Z38. Body mass index codes all had a very minor change, and that is the parentheses has been changed to a bracket. It does not change the code descriptors at all, but it's just making it more standardized. Z88.1 had a revision, and it took out the repetitive status in the sentence. And then the Z79, the excludes 2 was deleted, moved to an excludes 1 for Z79.4 because we would not want the long-term use with the oral anti-diabetic use. Foreign body encounters, this is for suspected foreign body that has been ruled out either by ingestion, aspiration, or being inserted. And then we are at our U category, and these are the special purposes. These were added at the beginning of the year. They're in the AAPC I-10 manual, it's at the end, it's not alphabetical. These are provisional assignment of new diseases of uncertain etiology or emergency use. So we have our first code, the U07.0 for vaping related disorder. You can see there's a number of conditions that fall under that. And then there's a use additional code to identify manifestations. These were actually published last October. They were not incorporated though until this year. Our other probably most used code of the year is U07.1 COVID-19. It has a use additional note for the pneumonia or other manifestation. The excludes 1, you do not report U07.1 COVID-19 with any of the other coronavirus codes because they are not as specific as the U07.1. There's also been a rumor floating around that there's a U07.2 for COVID-19, which there is a code. It has been approved by the World Health Organization, but not for the United States clinical modification. So as of this time, do not use U07.2. If anybody has reliable documentation that says to use it, I would love for you to send it to me. I've checked AHA and Coding Clinic, World Health Organization. I have found nothing that says we should be using it. So with that, Phil and John, I hand it back to you. Are there any coding specific questions? That was a lot of information in just an hour of fun time. Phil or John, do you want to take it back?
Okay, I'm not seeing much in the chat. There was a question about AAPC CEUs.
It does not. It was not sent in for pre-approval for CEUs, so no. But it's good information we need to know anyway. Anything else? All right, well.
Okay, thanks a lot, Brenda.
Everybody. Of course, anytime.
And we'll be seeing you again in 2 weeks.
Yes, ma'am.
All right. Just a reminder to everyone, there'll be a survey coming out. Make sure you fill that out. The other thing is Thursday, November 12th will be our next meeting with Brenda, Queen of Coding. She'll be going over E&M changes. And then November 19th, which is Thursday at noon, we'll be doing unconscious bias, invisible influences, lenses of bias that distort what's real. And Stephanie Moore will be presenting that one. So we look forward to seeing Brenda again in 2 weeks. Again, thank you. And don't forget to complete the survey. That helps us to know what we're doing wrong or what we need to do better. It's just a lot of valuable information. So if there's not any other questions, then we'll plan to see y'all in 2 weeks. Thanks, Brenda.
Thank you. Have a great afternoon, everybody. Thanks, John and Phil.
Thank you, Brenda.